Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Setareh Ziai and myself, Dr. Guillermo Rocha. We'll share our experiences as ophthalmologists today and tackle some challenges we face as healthcare providers. Are you ready, Setareh?
Let's do it, Guillermo. On this episode of EyeCan, we talked to Dr. Stephanie Baxter. Stephanie obtained her medical degree from Dalhousie University in 1998. She completed her residency in ophthalmology at Queen's University in 2003, followed by a fellowship in Cornea and External Disease in Philadelphia at the Wills Eye Hospital. She returned to the Department of Ophthalmology at Queen's in 2004, where she's been practicing and teaching ophthalmology ever since. She was the undergrad director from 2004 to 2012, and she's been the residency program director from 2012 to 2020. She's been in charge of implementing and operationalizing CBME at Queen's since 2015, and she'll be introducing it to all of us today.
Hi, Stephanie. It's great to have you on the podcast. How are you doing?
I'm doing great, Guillermo. Thanks for having me.
So we live in a world of acronyms and all these weird things and LOL and all these things that we see. So we sometimes get confused about CBD, or should we be saying CBME, Competence by Design? And, just as an aside, sometimes CBD may be confused with a cannabis byproduct by those who are not involved with this far-reaching change in medical education. What seemed as a smoke dream initially has become very real in the last few years, thanks to the hard work of people like yourself across the entirety of medicine. We appreciate you coming on and helping us to understand this competence by design, or what should be the correct term that we should use, and what does it mean, Stephanie?
So I kind of differentiate CBME and CBD. And so let me start by explaining CBME. CBME, or competency-based medical education, is a change in the philosophy of curriculum and particularly assessment in clinical medical education that we're seeing around the world. The purest form of CBME does not use time as a factor in determining competency and training, but rather the attainment of predetermined competencies. So it's kind of like the umbrella term, and in different countries, they have different names for it. So in the States, they're calling it the Milestones Project. And in Canada, we're calling it CBD, or Competence by Design. So it's our branding of CBME here in Canada. It combines time and the attainment of competence to determine a trainee's progression throughout residency to practice. So, like I said, the purest form of CBME doesn't factor in time, but I think at the Royal College, they're sort of realizing that there's a little bit of both. There's an importance of time in getting a certain amount of training, but also making sure that we really define what competency will be and what skills a resident has to have to graduate.
Okay, and looking at all of that, could you kind of sort of land it a little bit with a very specific example that maybe residents in different degrees of training, or some of us who have been in practice for many years, can better understand it with a very specific example, Stephanie?
Yeah, so a specific example. So just to go back for a moment, and CBD, as I said, kind of has some time in it, and they've changed PGY years. Those will still exist in terms of each resident as a year 1 or year 2 or year 3, but each resident will progress through a stage of training. So when you first get to residency, it's called transition to, I've already forgotten, transition to discipline. So you're kind of getting used to becoming a resident. And so it's the first month or two of a crash course of what it's like to transition from medical school to resident. And then after that, it's a foundation. So that kind of foundational knowledge that you need to kind of carry you through residency. After that will be the core. So that's when you kind of start doing subspecialty training and really getting into the nitty gritty. And then lastly, a transition to practice where you're really getting ready to go out into practice. So learning things that are more practical in terms of billing, running a practice, the day-to-day of practice. So an example, the other thing to kind of probably set the stage a little bit is to talk about the units that are going to be measured. And those are called EPAs, or entrustable professional activities. And they are very specific, sort of overarching skills. And so the example I kind of had here is that a person finishing up this EPA would be able to provide consultation on a personal ophthalmic problem. And so in the early stages, you might expect them to do things like foreign bodies and corneal abrasions. And by the end of the core in a cornea rotation, you might expect them to do things like, manage complex herpes simplex keratitis, and into practice, kind of putting it all together, seeing an undifferentiated patient and making sure that you're providing them the best consultation as an undifferentiated patient.
Stephanie, can you tell us, for those of us who, I think most of us are in some way or another resistant to change, can you try to explain to those listening, what was the impetus for this? Like what was wrong with the way we were doing it before, and why did we see the need to change this specific method of evaluating and having residents progress through their program and their training?
So the famous thing that the Royal College will talk about is the steeped T approach. So what they mean by that is a resident is in a residency for 5 years, and by the end of it, if you steep them in the environment long enough, they should come out an ophthalmologist. And I think that's a very broad, generalized notion of what was happening. Because I think we had defined competency and defined objectives, but I think the one of the real cruxes of CBD or CBME is that it should be direct observation. So I'm sure all of us can think about going to residency, and for procedural things, we're always really well observed. There's someone sitting with you at the microscope watching you do cataract surgery or your lid procedures. But some of those things like difficult conversations or getting informed consent, I don't know that I was ever observed doing that specifically. And so getting tips on some of these trickier things that are a bit more nebulous, there's some thought that being more specific about that will be helpful. And that if you define these competencies and that they're by stages, that you kind of can't get to the next stage until you've kind of done these foundational EPAs to get to the next stage. So I think it's intended to be a bit more deliberate. I think it's intended to be observed, and it's intended to provide very specific feedback on a day-to-day basis. Again, I think when we say that, the assumption is that we aren't doing that or we haven't been doing that. And I can tell you that for sure, back all along the way. I think it's just a matter of being a bit more deliberate about it.
Do we expect that this will affect student wellness, resident wellness, staff wellness in any positive or negative way, maybe in countries that are ahead of us in their CBME programming? Has anyone done any studies on overall wellness and burnout?
That's a great question. And I haven't actually looked at the literature specifically about that. But I think as you pointed out, change is difficult, and any can threaten wellness in general. And this isn't an insignificant change. We're kind of, it is and it isn't. I mean, I've often said that I don't think this really changes what we do day to day with the residents. I think we're recording or being more deliberate in what we're doing with the residents and recording, that feedback. But I do think that I can say from our residents and our faculty's perspective, I mean, it's a big change. There's a bit of a culture shift in terms of, instead of just giving midway and end of rotation feedback, you're now kind of expected to do that, record it daily. Again, I think we do it daily, but to actually take the time and record it. And then once you record it, you want it to be even more meaningful. So I think that's a bit of a time burden. There's more bureaucracy and administration with this in terms of tabulating all the data, because now you're getting multiple pieces of data on residents. So you need to be able to tabulate and look at that and review it. So you have more committees. You need to have a good electronic database or portfolio to be able to assess that. And so I think certainly faculty, and then when the residents, I've often heard them say, it sort of feels like they're in a fishbowl, that they're kind of always being observed and always being assessed. And sometimes I think that, although I think if you kind of look at it holistically, I think the intention is good and pure. I think sometimes it sort of seems like the residents are now chasing after assessments, and it sort of shifted it can shift the focus away from the actual objective of learning the skill and getting feedback, to now chasing assessments and completing what they need to get, the requirements for their portfolio. So yes, I do think I don't know what the studies are saying, but I do know that the transition is a big endeavor in terms of completely uphauling your curriculum and changing the paperwork. And now you have to provide a lot more assessment, specific assessments for different scenarios. So I think, and then the whole feeling you're being observed all the time, both faculty and residents, actually.
And so, Stephanie, I mean, looking at ophthalmology per se, and maybe I'll grab on an example of one of the core competencies that define us as ophthalmologists. Let's say cataract surgery. You're talking that basically it's the same approach, but now we're documenting more. We also mentioned the importance of time and sort of a timing factor in CBD, or competence by design. So let's say if you have, let's say in the process of cataract, diagnosing the cataract, interpreting lens implants, how to choose a lens implant, and finally the surgery. Would you see it now in CBD as more of a continuum, or would you still see it as independent things? You know, this resident knows how to select a lens. This resident knows how to select or diagnose a cataract. Or with this change, will you now have to sort of establish a time factor in that resident becoming competent from start to finish, and you have to assess that in some way?
Sorry, I may have confused you with the time factor. What I meant by that is, I'm sure many people have heard of the orthopedics program in Toronto, where residents were finishing after 4 years instead of 5 because they could accelerate based on their level of ability. Mm-hmm. And so that was a pure CBME model that kind of did not involve time. And so what I meant by time is that the Royal College is still requiring 5-year residencies to be 5 years. They're just not, so we're not shortening training by any ways. So I don't think it's necessarily being factored into specific EPAs that now you're going to need to have 6 months doing cataract surgery. I don't think the intention is that at all. So I apologize if I confused that a little bit. So taking the time piece out of it, what you described, I think the big challenge for the specialty committee is kind of the lumping and splitting of these EPAs. We all kind of know what we do on a day-to-day basis. Mm-hmm. And the Royal College provides like a milestone kind of little independent units of things that they suggest that all physicians should have. And they'll be putting that all together into a comprehensive curriculum that kind of suits everyone's programs to be able to deliver that curriculum. So to go back to what you were saying about the specific example of cataract surgery, if they sort of said, you know, the learner can now perform cataract surgery along that from the beginning moment where they assess the patient all the way to the follow-up and discharge back to the optometrist, each one of those items potentially could be a milestone, right? They could be kind of the stepping stones of which. So it depends on how they choose to define these things. The tricky part, again, is if you have, it's how much you lump it and how much you split it, right? Because the more you split it, then the more paperwork the residents are going to need and the faculty are going to fill out. But if you keep it too high level, then sometimes it's hard to really break it down into where the resident, what they still need to achieve. So it is a tricky thing. It requires 3 Royal College workshops, and our specialty committee has gone through the first. We were slated to do the second in the spring of 2020, and COVID hit. So that kind of had been put on hold, and we've now received an email where they're planning to do it again this spring. So we're getting back to our second workshop, and then a third workshop where we're going to kind of slice and dice the objectives in such a way that they're meaningful and that the programs can provide that educational opportunity to the residents.
So, Stephanie, has your team at Queen's University implemented this fully already, or are you still working on the planning process, or can you enlighten us on, it seems like you're ahead of the rest of us. Can you just let us know where you're at and how that's going for you guys?
Yeah, in 2015, our dean decided that Queen's, as in like all of our residencies, would become CBME by 2017. And so he pushed the envelope. So you may or may not know that the Royal College had a set rollout schedule where different specialties went. And so it was kind of a 5 or 6 year plan. And we were towards the end of that plan. And so when the dean announced that, it kind of, all of us were now going to go ahead. It kind of upset things for some of us who weren't, our plan wasn't to go until later. So we have 1 year left of traditional residents. Our PGY5s are the last group of residents in our program who are under the traditional program. And then the rest of our residents are under the CBME program. And I call it CBME because we don't have the Royal College curriculum to implement. And so when our residents kind of go through, we'll have the CBME residents who are the old CBME, what we've come up with. And then there'll be the new ones who are the CBD underneath the Royal College EPA system. So we are fully implemented and we're still tweaking. I mean, you can imagine that The reason we do this by committee is it's really important to get lots of input from different people and different programs and what they can offer and what's realistic and different specialties. And certainly I've sought lots of consultation from my colleagues, but under the tight timeline to really kind of get it sorted out, figured out, and implemented in 2 years. It was really quite quick. And so it's actually kind of fun now. I mean, it was challenging at the beginning, but it's kind of fun to now see it all kind of coming together. And although I don't profess to think that our CBME program will be what the Royal College adopts, I think our people on the ground will be ready for whatever comes, because we've already started to change our culture of daily assessment and using a competence committee to determine competence. So there's some new stuff that happens, and that we'll already have underway, no matter what the CBD curriculum brings.
So your junior residents know no other way, like this is how they've been from the beginning. Is that correct?
Correct.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
Hi, I'm Dr. Colin Mann. I'm a comprehensive ophthalmologist in Nova Scotia and current president of the COS, and I listen to the EyeCan podcast.
So now let's go to the other extreme, from the residents and even the junior residents to some of us who've been a few years in practice, and I won't say how many, but I'm happy to be in practice, and we need to update our knowledge, and we have new resources from the COS, the Practice Resource Center, and other things. How does this affect how we maintain our competencies, so to speak, how we learn new things? Does it apply to us as well in practice?
You know, when you look at the Royal College continuum, they certainly, within that diagram show people kind of transitioning into practice, within their practice, and even transitioning into retirement, and kind of that's all part of the continuum of our career. So I do think the intention is for it to somehow impact us. Exactly how and when and how they plan to accomplish that, I'm not sure. But I think we're already starting to slowly see that transition. If you think of our skills transfer courses at COS, in the Section 3 credits, you have someone beside you teaching you, and they're providing you an assessment. And that in some ways is along that lines. I mean, no one's kind of giving that rubber stamp of competence or anything, but, the assumption is that you're already in practice and you are already competent. And now you're just kind of furthering that knowledge. So that's kind of how I see it starting to permeate us at the in practice level, but how far, or if it intends to go any further than that, I'm not sure the intentions at all.
Do we have any idea, Stephanie, of what the timeline is for the rest of the country? I think I heard recently within our department, they were targeting April. I don't know if that's a provincial or a national date. Do you have any ideas about that?
I looked that up. We actually just got an email from the Royal College kind of globally to all of us with the new implementation date. So originally we were supposed to start our workshops in 2019, which we did, and have it all kind of wrapped up and start implementation in 2021. That was the original plan. But then as they started to roll out programs, things seemed to get delayed. So it wasn't clear if we'd stay on that track or not. And even maybe it would have been 2022. But by no means are we ready. What you might have heard about for April is a second workshop. The second workshop is just that group, that specialty group getting together again at the Royal College to try to come up with the curriculum. And so there'll probably be a third workshop, I would think probably in the fall. And then they have to work on translating it and all of that. So the go live date is probably guesstimating a couple years away, and when I looked it up, they actually didn't have a specific date for ophthalmology. So there are some programs who are going live in 2021, but then after 2021, they actually had different programs that still needed to go live and didn't even speculate on a timeline. So I think it's still up in the air.
Which might be a good thing, I guess, with COVID. There's new already happening around us and so much unexpected and so many last minute changes with COVID that perhaps this would add another layer of sort of complexity to the CBME implementation. So maybe it's a good thing that it might be a bit delayed.
Yeah, I didn't think of it that way, but I think we are all there's been so much rapid change anyway, and then hit COVID with the uncertainty amidst the rapid change. I think that it would just be a lot. So I agree with you full-heartedly. And certainly early on in COVID, we were a little bit worried about being able to provide the appropriate educational opportunities. I wouldn't say that was CBME or CBD specific. I think just in general, programs weren't sure how we were going to deliver cataract education when no cataract surgery was being done.
Right.
Thankfully, things have opened up in that way. I would still say I don't know across the country, but we are certainly a little bit reduced capacity. And so we're trying to use other things like supplementing with wet labs and simulators and good case discussions to try to supplement that as best as we can, and trying to make every surgical opportunity count in some form.
Yeah, and so you're mentioning a little bit of that use of technology for teaching. There's also the technology we use on a day-to-day basis as ophthalmologists, and also, I guess, the changes with COVID in terms of implementing more and more teleophthalmology and learning to use that technology. So have you seen any modifications to the CBD program and the planning based on all of these three things?
So I would say, CBD or CBME is heavily invested with technology, because at the very minimum, you need to have some sort of electronic platform to store this multitude of data and be able to analyze it in some meaningful way. So I remember when I took on the program directorship many years ago, I was kind of excited about this opportunity. But I said, listen, I'm not going to implement this implementing any of it or trialing little things until we have a platform, because having thousands of little pieces of paper that you then kind of have to somehow make meaningful seems almost impossible. So I would say an electronic platform that has some, phone capability, like app capability. Early on, we didn't even have an app for assessments. And so everyone had to go on to the computer and be online to be able to send out assessments and complete assessments. So now at least you're in the app era where you can quickly tap the app and complete an assessment. And there's still some room to go with that. In terms of, you'd mentioned, what other technologies had you mentioned there, Guillermo? Can you remind me? Just
the regular technologies we use, how to assess, the resident's performance of YAG lasers, for example, or other types of lasers. And also the teleophthalmology as well. Are you seeing those shifts in terms of evaluating and assessing a resident while implementing those technologies?
Yeah. So early on, the program Dr. Bona and I spoke about how because early on, that's all the ophthalmology we were doing. And we didn't want to we thought we're struggling to figure this all out. And this may become the wave of the future in some capacity. Like, we definitely need to make sure that this is an educational opportunity. Mm-hmm. I definitely see that as being, now that we've experienced it, I definitely see it being one of the EPAs in some capacity, being able to provide care, understanding its limitations and opportunities. We haven't gotten there yet because we've gotten to go back online, but I would be really surprised if we don't implement something like that into our EPAs, because I think it will be critical. I mean, there is some opportunities in ophthalmology, and there certainly are limitations, and in some cases just it's impossible to do anything because we need an up close view. So I think that will be a critical thing to discuss as a EPA or a competence at some level.
Stephanie, I'm going to ask you a really hard question. Can you tell me what you think are the two best things and the two biggest challenges with your experience with CBME at Queen's?
Yeah. I think that off the cuff, because if I gave it some thought, I could probably come up with some really great ones, but off the cuff, as we're kind of going into our finishing up our fourth year, I think the assessment piece is good for the residents. Again, not necessarily that feeling of being under a microscope, but it makes us as educators really reflect about the feedback that we're giving. So, back in the day, you're often told just read more or great job, but we're really thinking about, how do we get the resident to that next level, if you will. Really good educators are already doing that. So again, it's not going to be any surprise, but on all of our forms, The university doesn't call it, things that were good and things that were bad. They call it, what are the next steps for development? And it really makes you think about, okay, that was a great cataract surgery, but maybe the next step is to try to reduce your phaco energy or be more efficient with your second instrument. I think that's probably the biggest advantage, is really causing us to reflect. I think having more direct observation, although I will admit that is a challenge as well. So it's an upside if and when you're able to do it, but it's a challenge because it's not something that we're used to doing. I go into a patient encounter with a resident, they tell me the story. So I kind of, without directly observing how they get that story, I deduce that they did a good job if they gave me all the facts that I was looking for. And I assume when they tell me about the findings and I double check the findings, that they actually did that accurately. But I think there is probably some value in actually observing and making sure that it is being done, if not in the most efficient way or the most accurate way, and being able to give them pointers that way. So I think that's probably a perk and a challenge, because it's really hard to do that. As soon as you're in the room as a the attending, as the attending and the person that the patient's there to see, the dynamic between the resident and the patient changes. And it's also not potentially effective use of your time. Oftentimes, as you know, things are happening concurrently. The resident's seeing a patient and you're seeing a patient, and they come and review, and that allows kind of everything to kind of flow more smoothly. And it's just a bit more practical. So I think there are some challenges that can be overcome there. We invested in some CCT video camera technology where we don't have to be in the room. And so we have that in our emergency eye clinic where we can observe residents, and we don't have to observe the whole encounter, and we can observe different residents doing different things at different times. We've coupled the video camera technology with slit lamp cameras with videos so that we can observe them from another room. So that way we're getting a more natural, and we have signs so that patients know about this being a possibility, and they have the ability to decline being, observed. So from patient and from a patient privacy or patient wishes perspective, it doesn't have to happen. Initially, I think the residents really felt like they were being observed in an fishbowl at that time, but they now realize that we aren't always watching. We aren't always watching them. We can kind of come and go. And so I don't know that it's being used to its full potential, because again, there's a bit of a culture change to actually do that, sit there quietly and kind of bounce from room to room and kind of see what the residents are doing. But I think there's a lot of innovative ways that try to do this in an efficient, effective way.
Good. And Stephanie, after all this work, all these assessments, how do you think this will translate into our patient care? So these first group of residents that go through this program, what can you tell the patients to expect afterwards in terms of their care?
That's a great question. And I remember when the Royal College came to our specialty committee, that was like the philosophical question that was asked, why are we changing a system that already seems to be working? And ultimately, how is this going to impact the final product? Do we really have any evidence that it makes a difference? So one, it's hard to measure. And two, there are already really great quality ophthalmologists out there. So I think it's going to be really hard to say that. But I think you asked me earlier, Setareh, why we're changing this. And one of the other things that the Royal College does is to have some more public accountability. And it's not just that you've steeped in a 5-year residency and then we're set loose, which again, I think is not a great representation, but that, all the things that we felt were super important, in terms of training future ophthalmologists have been observed in some capacity and assessed in some capacity at a kind of more granular level. So I don't know that we'll have evidence or proof, but we'll have documentation that actually occurred.
Well, Stephanie, thank you so much for joining us tonight. That was a really interesting take and some much needed clarification and education on CBME. I know many of us from across Canada have been hearing more and more about this in the past, increasingly in the past few years. And we really felt like we needed to bring an expert on to explain it to us better. And I think you've done such a great job of doing that for us. So thank you very much.
Yeah, thank you, Stephanie.
I'm not sure I could be considered an expert. I think more I'm learning as I go, and have had sort of more experience than anybody else in our field. But one thing I would say is that if people are curious and want to know a bit more about it, the Royal College website has just gotten better and better as time has gone on. And it's a really great place to kind of wet your whistle about information with CBME and CBD if you have more interest in knowing more.
Perfect.
Thank you.
Thanks, guys.
Thank you.
Thank you to our guest, Dr. Setareh Baxter, for joining us. We look forward to bringing you more episodes. Here's what's coming up on our next episode.
Hi, my name is Dr. Clara Chan. It's nice to be here and be invited to be part of this podcast. I'm a specialist in cornea, cataract, and refractive surgery at the University of Toronto, and I teach the residents and fellows as part of the fellowship program there and residency program. Currently, I'm also the medical director of the Eye Bank of Canada Ontario Division, and I recently took over as president of the Canadian Cornea Society.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
The EyeCan podcast is funded by MDF Affinity Grant. It is brought to you by the Canadian Ophthalmological Society, directed by Eric Johnson, and produced by John Allaire from Allaire Strategic Works.